go ahead and get started for tonight's ASJ Journal Club. I'd like to thank everybody for tuning in for this Next Generation Editor edition of the monthly recurring session of the ASJ Journal Clubs. My name's Ryan Austin. I'm a plastic surgeon in Toronto, Ontario, Canada, and I'm the lead of the NGE section. I'm joined tonight by some fellow NGEs. We have Dr. Maryam Zamani, who's going to be our discussion curator tonight. She works down the road from me in Oakville, Ontario, and she's going to be moderating the chat box for us tonight. So make sure that you follow along in the chat. If you have any questions, if you have any comments, feel free to write them in. If you have any questions specifically for our discussants as we go through the talk, feel free to write them in, and you're going to see multiple polls come out throughout the night, and we will touch back to those, so feel free to answer those as they appear. Tonight, we have another one of our Editor's Choice articles hot off the presses from the May issue of ASJ, entitled External Approach to Buccal Fat Excision in Facelift, Anatomy and Technique, and its accompanying commentary article. And we're fortunate enough to have some expert discussants with us here tonight who are going to provide us some great insights on this article. Tonight's event really is a global affair, and we are joined live from South Korea by Dr. Ki-hyun Andrew Cho, who's a co-author on this month's article and a fellow member of the ASJ Next Generation Editor team. After completing his plastic surgery resident in Seoul, South Korea, he went on to complete an aesthetic surgery fellowship here at the University of Toronto, followed by a fellowship at the Cleveland Clinic in Cleveland, Ohio, where he worked on this research tonight. Andrew is now in practice in South Korea, and this past week he actually took over our ASJ Instagram account for our first Korean language interview with Dr. Roy Kim from San Francisco, California. So I encourage everyone to take a moment and head over to the ASJ Instagram account to watch that, and I appreciate Andrew being here tonight. We're also fortunate to be joined by the senior author from this month's article, Dr. James Zins, and as the chair of the Department of Plastic Surgery at the Cleveland Clinic in Cleveland, Ohio, Dr. Zins is a world expert in plastic surgery and particularly in facelift surgery, having published over 250 peer-reviewed papers, numerous book chapters as well. As a past president of the American Association for Plastic Surgeons and a current associate editor for the face section in the Aesthetic Surgery Journal, it really is an honor and a pleasure for us to have Dr. Zins here with us tonight. And completing our trifecta of expertise, we're also joined by Dr. Dino Alyassnia from San Francisco, California. Dr. Elyassnia completed his MD degree at USC School of Medicine before going on to complete a combined residency in general and plastic surgery at University of California, San Francisco. He then traveled to New York City to complete a fellowship in aesthetic surgery at the New York Eye and Ear Infirmary with Dr. Donald Wood Smith before returning to San Francisco and joining into practice with Dr. Timothy Martin. With a practice focused almost entirely on rhinoplasty and facial rejuvenation, Dr. Elyassnia is regular on the podium at most aesthetic surgery meetings, and I'm sure you'll recognize him. So thank you so much for joining us tonight as well for your discussion. It's getting harder and harder to introduce all these experts, so I will just hand off the microphone to Dr. Cho for his presentation tonight and to start off the Journal Club.
Thank you, everyone, for the opportunity to present our study on external approach to buccal fat excision in facelift. My talk will be focused on cadaver dissection results. Then Dr. Zins will give a talk about surgical technique and clinical results. We have no disclosures. Aging is attributed to deflation and descent of the mid-face jowls coupled with skin laxity. In a small percentage of this population, a fullness is evident lateral to the jowl. We and other groups have observed this clinical to be prominent buccal fat pad, and this all results in masculinization of the face, which is a common finding in facelift patients. Objective of our study was to examine the anatomy of the buccal fat pad and triangulate the prominent buccal fat pad with surgical landmarks through a standard facelift dissection approach and describe safe and accurate approach to buccal fat pad external excision. 18 hemifacial fresh cadaveric specimens were dissected in supine position to simulate facelift surgery, and a submass dissection was performed to localize the buccal extension of the buccal fat pad. The measurements were taken from the center of the buccal fat pad to known surgical landmarks. inferior border of the zygomatic arch, anterior border of the tragus, and gonial angle, and oral commissure. Location of the buccal branches of facial nerve and parotid duct relative to the buccal fat pad was also recorded. And lastly, the vascular pedicle and the quadrant in which enters the buccal fat pad was recorded. Here are the results. The buccal extension of the buccal fat pad was located approximately 7.5 anterior to the tragus, 4.5 centimeter medial to the gonial angle, and 4.1 centimeter inferior to the zygomatic arch. And the average distance from the buccal fat pad to oral commissure was about 4.3 centimeter. Vascular pedicle to the buccal extension of the buccal fat pad was a branch off of a middle facial artery, and it entered the fat pad on posterior surface in the inferior lateral quadrant in 61% and inferior medial quadrant in 39% of our specimen. And parotid duct traveled on the superior aspect of the buccal fat pad capsule, and the buccal nerve branches coursed on the superficial surface of the capsule. Now, Dr. Zins will give us a talk on surgical technique and the rest.
Okay. All right. I just want to enlarge this. Okay. All righty. Well, thank you, Andrew. That was a very nice presentation of the anatomy of the buccal fat pad. Again, I'd like to thank the co-authors. This is actually Chris Surik. My former fellow was the first author on this paper. Andrew helped Chris with the anatomy in the cadaver lab, as did the others. Actually, Jennifer McBride and Richard Drake, they run our anatomy cadaver lab, so we include them always on our publications. Pseudo herniation of the buccal fat is not new. Actually, Jim Stuzen, as a fellow, described the anatomy of the buccal fat pad and some clinical examples way back in 1990. Alan Matarazzo was really the first to describe so-called buccal fat pseudo herniation. And his description, he actually presented 7 papers, 7 patients in this 1997 publication, and they characteristically presented with a discrete walnut-sized lesion lateral to the jowl and freely reducible. Jose Guerrero Santos actually wrote an editorial on the Matarazzo paper back in 1997, and he described actually 3 variants of patients presenting with a buccal fat pad, so-called pseudo herniation. Alan had a repeat update back in 2003, and David Nyes then wrote a very apt commentary in PRS on the Matarazzo second paper. So, pseudo herniation of the buccal fat, as described initially by Matarazzo and others, presents, as I said, as a discrete but reducible cheek mass, and this differentiates it from salivary gland tumor, hemangioma, or other possible diagnoses. As far as the clinical pathophysiology, it's fairly consistently agreed that this represents weakness in a parotid mesenteric fascia and SMAS, as detailed by David Nyes and Alan Matarazzo, and confirmed by our dissections. Jose Guerrero Santos also suggested this may represent an anatomic variant, and this was clear in his 3 descriptions. All of these authors addressed the buccal fat pad through an intraoral approach. And this really was the inferior portion of the buccal extension, which drew out our clinical interests. And then finally, all agreed that this was readily corrected by buccal fat intraoral excision. This figure actually is the nicest description that I could find of the buccal fat pad. And the buccal fat pad is described in either 3 components, and that is an anterior, an intermediate, and an inferior component, or I think more aptly, a buccal extension, a pterygoid extension, a superficial extension, and then a temporal extension. And so as you see here, the buccal fat pad represents a sausage-shaped structure, and the area that we're concerned about clinically when it comes to facelift surgery and pseudo herniation is this buccal extension that you see inferiorly. Interestingly enough, again, this paper, how did this paper come about? Well, it came about because, as so many other papers do, because of a clinical observation. And what we found was not that we made this diagnosis preoperatively, but actually we made the diagnosis intraoperatively, and we found it consistently in secondary facelifts, where on opening the facelift flap, we would find buccal fat protruding through the parotid mesenteric fascia and the thin SMAS anteriorly, just lateral to the jowl. So this, in our first several cases, was actually not a preoperative diagnosis, but an intraoperative diagnosis. And additionally, what we found was we noticed this weakness and this slight protrusion, and then on SMAS manipulation, either SMAS plication or SMAS elevation, we found that this actually exacerbated the deformity, really calling for resection of the buccal fat buccal extension. And then finally, this clearly, we corrected this directly via the facelift flap, as opposed to making an intraoral incision. And actually, incidentally, in Alan Matarazzo's second paper, he described addressing some of these patients via the facelift, doing it at the time of facelift, but actually having a separate table and making a separate intraoral incision and excision to remove buccal fat. Contrarily, we did this at the time of facelift directly through the facelift flap. So here we are in surgery. The ear is at 6 o'clock. The nose is at 12 o'clock. We've opened the flap, subcutaneous dissection at this point, and you see the buccal flap fullness at about 12 o'clock. We've now opened the capsule, the parotid capsule, made a small incision in the capsule, and then tease out the buccal fat, and then resect that buccal fat over the Q-tip, as you see here. Another patient, again, small incision through the capsule, the buccal fat pad, and then teasing out the buccal fat, and then carefully excising the buccal fat, realizing that facial nerve branches, buccal branches, are going to be coursing superficial to the buccal extension. And here, again, another patient, bipolar cautery of the buccal fat serially to excise it until there is no longer a bulge. And then finally, closure of this by reapproximating SMAS over the flap. And again, Andrew has described this for you. The easiest measurement that we make is really that 4.3 measurement from the oral commissure to the apex of the buccal fat. But measurement's really not critical because this buccal fat extrusion is obvious on elevation, on flap elevation. So again, landmarks as depicted by Andrew so nicely. Again, important anatomy, invariably in the Zurich cadaver study and the study that Andrew and Chris did, the parotid duct invariably passed superior to the buccal fat pad extension and is really not in the surgical field. The buccal branches of the facial nerve, again, passing lateral or superficial to the buccal fat pad, and they do need to be carefully looked for. Cadaver dissection, again, the Zurich Andrew Cho dissection. You can see the ear at 7 o'clock. The chin is at 2 o'clock. We've resected the bone. We've resected zygomatic arch, and we've resected a portion of the mandible. You see the buccal extension here, a large buccal extension glove paper under the parotid duct coursing superiorly. And then the sausage, think you can appreciate the sausage-shaped buccal fat pad with its temporal extension at approximately 9 o'clock near where the wording says parotid duct. So an example of the patient, the buccal fat extension, the pseudo herniation of buccal fat can actually push the jowl inferiorly and laterally, making it more apparent. So again, with careful preoperative evaluation, this may be noted, but again, this is something that we've noted, at least initially, only intraoperatively. So you see the before pictures on your left and the after pictures on your right, and this patient is at 7 months post-op. So in summary, pseudo herniation of the buccal fat exacerbates the jowl deformity, pushes the jowl laterally and inferiorly. The pathophysiology represents weakness in the parotid masseteric fascia and the overlying SMAS, which extends medially. It may be apparent preoperatively, but you need a high index of suspicion. Again, we initially found this only incidentally intraoperatively, and is readily corrected through a facelift incision with care to recognize the importance of the anatomy of the buccal branches of the facial nerve and the parotid duct. Thank you very much.
That's excellent. Thank you so much, Dr. Zins, and also Dr. Cho for your presentation. I'll hand the microphone over to Dr. Elyassnia for your thoughts and comments on this paper, as well as kind of buccal fat pad resection in general.
Yeah, I wanted to congratulate the authors. That was a great paper. My experience is exactly the same as Dr. Zins just sort of laid out. This sort of pseudo herniation, I've definitely seen, and exactly as he says, just lateral the mouth, there's this reducible lump there. I've missed it preoperatively, but I've also diagnosed it preoperatively. If you start looking for it, and you can find it, but it's not extremely common. It is in secondaries, just as he said. So I think there is this phenomenon of weakness, from tightening the SMAS. Maybe we're over tightening SMAS, and it creates an area of weakness and herniation, especially with more aged patients, and weakening of the tissue. I've never removed it externally. I've whether it's young patients or this group of patients, I've always used an internal approach. I was assuming that he was doing SMAS flaps, and it's kind of an easier pathway right to it. So I was interested. It was interesting to me to see that they're going, making an incision directly through, and I think those landmarks can really be helpful, because it's more obvious if you're sub-SMAS and you're looking through parotid masseteric fascia and seeing the fat there. So I think this is a very useful paper, especially I think for younger surgeons. When you don't know the anatomy really well, it's nice to have basic measurements and landmarks to help guide you. I always loved papers like this when I was first learning, because it gave you something to rely on, to help guide you when you didn't have the experience, so this will be a very useful paper, I think. My only other kind of main point is, overall, I'd say, just to put this into a little bit of perspective, most of the time I'm actually adding some fat sort of over the buccal space. When I fat graft the lower eyes, mid face, cheek, I'm usually blending down, into the preauricular and buccal area. So I think the average case, we're, with kind of pan-facial volume loss, we're adding volume in these regions. So I think it's good just to keep it into perspective that these are less frequent findings, pseudo herniation, compared to the opposite scenario, which we're adding more often than we're having to reduce this. So just to kind of put into perspective a little bit.
And Dr. Zins, I'll just jump on what Dr. Elyassnia said. Are there any technical differences or nuances, would you say, for those working above the SMAS doing only plication or a SMASectomy, and those who are working under the SMAS raising a SMAS flap? Or is it similar once we get forward using those anatomy and that landmarks to try and do this from that external approach?
I don't think you're going to be under the SMAS that far medially, or else you're going to put yourself in grave danger of injuring facial nerve branches. So, we're going to be above the SMAS this far medial almost always. Again, it's very obvious when you see it in the operating room, and I agree that good high index of suspicion is reasonable. You may be able to make diagnosis ahead of time, but I think you're going to be above the SMAS. And again, what happens is the SMAS is the SMAS, as we know, thins out as we go medially, no matter what. But then when you're doing these secondaries, and I agree, it may well be that what we've done is we've pulled on the SMAS, so it's sort of like tightening that belt on that fat belly. You tighten that belt, and then the belly's going to stick out. So you actually are pushing that. I think you're constricting the face in the deeper tissues, pushing that buccal fat out. Or the other possibility may be some patients just have a larger inferior extension of that buccal extension. It may be that there is actually more fat in there. And again, we just don't have the data to really answer that question.
And do you think that there's any difference in risk to either the parotid duct or the facial nerve coming from external versus internal, or with these measurements and knowing that it's going to be above and superficial, does that help us to protect it?
Ryan, it's pretty, again, when you see it, it's pretty obvious. I mean, I think it'd be pretty hard to injure a buccal branch. I really do. You go right over that. What you do is you just sort of, you see that fullness, and then you just take a little nip of it, like you're opening the fat pockets in the lower lid. Just take a little nick, and then you just tease that fat out and just looking for those nerves. Is there any nerves that are sitting superficial to that buccal fat that you could see that buccal fat sitting, very similar to the lower lid, very similar to how you would treat fat in the lower lid. And I think it would be hard to injure it. I think there was a question. I think Ann Taylor had a question about how much fat to remove. And it's very obvious that there's a lot of fat there that's going to create a problem post-operatively if it's not removed. So again, make a nick in there like you're opening the medial or fat compartment of the lower lid. Tease that fat out until it's just flush with the rest of the SMAS layer. And don't over resect it, and don't pull too hard. Just like the lower lid.
And Dr. Elyassnia, maybe just for our viewers, we're talking a lot about the external approach. Maybe you can review just basically your internal or intraoral approach to buccal fat pad excision, so that some of our attendees can get a little insight to that.
Sure. Yeah. Intraorally, I think the kind of classic description of the incision was sort of just lateral to the first molar. But I liked making it a little lower. Sometimes you can actually, if you use your hand to sort of push the cheek inward, sometimes you can actually see see a little fat. If you're lucky, you can kind of get a sense of it. But I like an incision sort of a little bit lower. So maybe, around like 6 o'clock to the duct or something like that. And sometimes you get lucky, you make a stab incision and the fat comes right out. So doesn't need a big incision. And then as Dr. Zins is describing, internally, it's the same. You kind of can tease it out. It's pretty avascular, you sort of tease it out. And then once I just can't sort of tease anymore, that's about seems like the right amount. And then, you can ligate it. Sometimes, just, basic cautery. And it's a pretty small incision, so you can maybe not even close it, but I usually put a single, chromic or two. It's a nice, simple way to do it internally. And, maybe one advantage is that you don't weaken it superficially. And, one worry I always had is if I go external, not that I've ever done it, but you might create some weakening in this mass. And but I guess if you're removing the fat, you've treated the problem anyways. So
You know, Dino, I just let's be clear though. I think we should differentiate pseudo herniation, the treatment of pseudo herniation of buccal fat, from buccal fat removal, bilateral buccal fat removal for aesthetic reasons. These are two
Sure.
very different situations.
Yeah, definitely.
And also the post-op recovery is very different. You get the immediate result when you correct pseudo herniation. On the other hand, at least in my experience, is swelling is a significant problem with buccal fat removal for aesthetic purposes, and it takes quite a while for that to calm down. So I think
Yeah.
these are two very different instances.
Sure, I'd agree with that. I mean, I don't have a huge experience with, you know, I'm pretty conservative overall with buccal fat. I think in the young population, it's, you know, there's a social media trend of, you know, these really contoured cheekbones, and I sort of, you know, worry about that a little bit. So I only do it if they really have that sort of clear, you know, chipmunky look. If they're just trying to look a little stylized at a younger age, I'm not a big fan of it. So I don't do a huge volume. And the pseudo herniation, you know, it's probably, I've only done it on one hand. I could probably count the number of cases I've done, but I've only been practiced 11 or 12 years.
Yeah, there was one question about, you know, what's the complication rate of pseudo herniation? Well, I'll tell you, if you don't treat pseudo herniation when it's there, your complication rate is going to be 100% because the patient's going to have a deformity.
And it'll be more obvious post-operatively.
Right.
You've treated that laxity around it, you know.
Right. Exactly. Again, you're tightening that belt, and you're going to push that fat out more. It's going to be more of a problem. So if you don't treat it, you got a complication rate of 100%.
Yeah, I agree.
And Dr. Zins, when you're correcting the pseudo herniation, so you've made your incision, you've removed the fat, are you simply closing that SMAS layer back over, or do you do any imbrication to try and correct the pseudo herniation and tighten it up even more?
You know, Ryan, I think that's a good question. You know, I just closed the hole. I just closed the defect. You know, again, you are around the branches of the facial nerve, and I think if you're getting too aggressive, it's possible you could catch a buccal branch when you're trying to close that. So I just make sure I see where my bites are, and I close the hernia.
Great. So maybe with that, Maryam, we've been seeing a lot of poll questions flash up. Maybe you can go through some of the results of our attendees tonight.
Absolutely. It's been really interesting actually following along. It sounds like a fair bit of our attendees, 73% of them have actually done intraoral buccal fat pad resections. Less commonly have tried the external approach. About 60% have not done it with combination with the facelift or otherwise. And actually, it sounds like, I know today we're talking about pseudo herniation, the older population that we're seeing, but most of our attendees have actually been using the indication of treating for more cheek contours in the younger population, 60% as opposed to 33% that are doing it for pseudo herniation, the older population. And I think that's clearly driven a little bit by the social media trends and what patients are coming in asking for us. They're more aware of the buccal fat and how it can contribute in terms of the cheek contour, whereas the pseudo herniation, as Dr. Zins and Dr. Alyassnia are talking about, is something that it takes a trained eye to really become keen observer for and to try and see it preoperatively and to address it safely intraoperatively. And from our attendees that have done this surgery, it seems that there was just a small percentage that had experienced a hematoma using any kind of this approach. But after this really great discussion, it seems that a lot of our attendees are excited to attempt to do this surgery in the future, look for the clinical indications. They feel more comfortable doing this using the external approach. So definitely having the intended effect that we're looking for. What I want to do at this point is actually, we have been getting some questions through the chat box as well, and I want to give that due diligence as well. So I have two questions actually from Leslie Stevens. The first one, I'm going to address it to you, Dr. Alyassnia, because you indicated that you have looked for this clinical sign preoperatively. And if you can walk us through it, do you just palpate where you expect the external buccal fat pad to be, push it in and see if you get that slow gravitational pullback? Is that how you're diagnosing it? Or do you have other clinical indicators that help guide you to know that you're looking for buccal fat pad possibly?
Yeah, I mean, it's a distinct entity other than the jowl. So I don't know, you just have to be looking, you have to notice it. I guess you got to see it once, and then I think once you see it, you'll recognize it again in the future. But once, the other way would be if you have just to have that index of suspicion, and if you see something that you feel like looks a little separate than the jowl, just something slightly more superior, make an attempt to touch the patient's face, and if it reduces, it's sort of pathognomonic,
Yeah, break all COVID rules. Right now we're diagnosing that's here. Doesn't apply.
Dr. Zins, do you have any other tips? I don't know how to.
I would say, take a look at Matarazzo's first paper, the 99. I know it's an old paper, 1997 paper. You look at those 7 patients, and it is blatantly obvious. It's a walnut-sized mass that's
Right.
actually posterior to the jowl. It's very, very obvious. When I see it, it has not been very obvious. As I said, I didn't even make the diagnosis on the first 2 patients that I saw. So it can just be an exacerbation. It may just present as an exacerbation of the jowl, pushing the jowl inferiorly and laterally. So, it probably comes in all sizes.
Perfect. I'm just going to add a little tidbit nugget. I trained with Dr. Jim Grotting, actually, and we did do a fair bit of buccal fat pad assessments and removals. And one of the pearls that he had is definitely you would reduce it. And when you let go, you see that it's a very slower descent back into the space. And if you have the patient smile, it's a much more rapid exacerbation. So that might be a helpful indication for patients as well. Leslie Stevens had a second part to her question, so I'm going to ask that because I think this is interesting since we were talking about how the fat pad, the buccal fat pad, sometimes we're comparing it to be akin to the lower eyelid fat components. She's asking about, has anyone thought about doing preservation, repositioning of the fat to a deflated area? Of course, that has some anatomical considerations taken into effect, but if you don't mind commenting on that, that would be great.
Yeah, can I comment on that? And I would really just like to, this paper has sort of been a Cleveland Clinic deal. If you look, when you go to the May issue, Ozan Bidic wrote the commentary on this paper. And I'm proud to say that Ozan was one of our best and former residents. He's gone way, way beyond what we taught him as a resident, and he's really becoming a senior surgeon, master surgeon in Turkey, great rhinoplasty surgeon, great facelift surgeon. He actually has a paper, and the reason they asked him to comment on that was to do just what you suggested, Marianne. And he was taking that buccal fat, he was teasing that buccal fat and using that buccal fat to augment the malar area. So, and there is an ASJ, he wrote an ASJ paper on that topic. So kudos out to Ozan. It's great when the student's teaching the teacher, I'll tell you.
Fantastic. And to follow up another question I see that's popped up on the chat box, either of the discussants, if you feel you'd like to approach this, it's an anatomical question. When you're approaching the buccal fat pad from either an external or an intraoral approach, are you removing the same component? So I think this is more addressing sort of the anatomy of that buccal extension, if you guys don't mind commenting.
Well, I'll be happy to comment on that. Okay, so if you're approaching, again, let's think about the anatomy. We've got a buccal extension and we got a pterygoid extension. You're making the incision between the first and second molar, maxillary molar, so you're approaching that pterygoid and buccal extension. So I think the answer is yes, you're removing this, you're removing the same, the clinical area of interest is the buccal extension. That's what you have to remove.
That's great. Maryam, do we have any more questions that have come in or?
No questions that have come in. I do have a personal question, actually. I wanted to know from Dr. Zins whether in your experience having done primary and secondaries with approaching this fat pad bulge, do you find that in a secondary patient, your landmarks of where you're seeing that bulge are changed because of that, the movement of this mass that's already happened? Or do you think this sort of intersection of the measurements still applies similarly?
Well, yeah, I tell you, Marion, I don't really go by those measurements. You know, again, I raise the flap, and you know the bulge is apparent, and it's really in the masticatory space. So it's just anterior to the masseter, or it can actually overlie the parotid masseteric, the masseter and parotid masseteric space area. So I think that it's again obvious intraoperatively, and you know those measurements are a little bit hard to convey from your underneath the flap. You know, it's not an external mark. I guess next time I'll look and see if it how it configures.
That's great. So, you know, seeing this is the whole purpose of this journal club is we take these topical articles that are hot off the presses, and to see 60% of people, respondents tonight, thinking that they may try this or incorporate it into their practice not only speaks to what an amazing article this is and how accurately it defines things, but the expertise and the kind of thought that's gone into this. So Dr. Zins, for those who have tuned in and maybe considering to try this on the next patient when they're in the operating room and they see that pseudo herniation, what's the kind of number one trick or tip or thing that they have to keep in mind that you take out of this paper when they're going to go ahead and make that cut and try and take out the buccal fat from an external approach?
Well, Ryan, I think it's, you know, again, plastic surgery in general and aesthetic surgery in particular is basically applied anatomy. And if you're comfortable with the three-dimensional anatomy, you're going to be able to figure out all these things. And again, I think that the anatomy is pretty clear. And I think treating this problem when you see it, now that it's been brought to your attention, is also pretty clear. And I think it is fairly problem-free, because I think you'd recognize a buccal branch as you teased out that buccal fat before you cut it. So I think I would encourage the audience. I don't think you need a lot more than this article to be able to diagnose this problem and to treat this problem without running into complication. It's avascular. You don't see those vessels that Andrew described. I mean, Andrew described them aptly, but those vessels do not come into play because those vessels are inferior and posterior. So all you have to do is worry about that parotid duct, which is invariably going to be superior, and the buccal branches, which are going to be lateral. But again, just tease them out, just like you're not going to cut the muscles in the lower lid, and I think you'll be safe.
That's great. Thank you so much. With that, we're approaching 8:40, which is the natural endpoint for these sessions in the plan. So we don't have any more questions tonight. So I'd like to thank all of you for attending. I would like to thank Dr. Cho for tuning in from South Korea. I'd like to thank Dr. Zins for his expertise and Dr. Elyassnia for his discussion. These journal club sessions are a great way for us to all learn from each other and to take these kind of hot topics and put them out there so that we can chat about it. So thank you all for taking the time out of your schedules to come in. I look forward to seeing everybody back. We will be back in 2 months for the next NGE Journal Club, the first week of July, but watch out for the Young Aesthetic Plastic Surgeons Journal Club, which is going to be coming up the first week of June. You'll see emails going out for that come the end of the month. And so make sure you sign up, register, put this on your calendar to tune in monthly. So thanks again, everyone. Have a great night. Stay safe and stay healthy, and we'll see you soon.